Thank you. Is my screen visible?
Yes.
Yeah.
Hi. So, very good evening, one and all. Uh, on behalf of YOSI and YOSI Retina Focus Group, I welcome you all for another exciting session of YOSI Retina Surgical Wars. This is our small Retina Focus Group under the guidance of Governing Council. So, for today's exciting session, we have three great warriors whom we know. They are very great speakers as well as presenters. First up, we have Dr. Apurva Ayachit, who will be speaking on small eyes, big challenges in coloboma size. Next, we have Dr. Kushal Deliwala. He's a eminent surgeon in Ahmedabad who will be speaking on macular IOFB peeping through rosette. And last, we have a young dynamic retina surgeon, Dr. Sarang Hansraj. He will be speaking on battling RD in an eye with massive atypical coloboma. I welcome all the speakers. For today's War Council, we are very grateful and thankful to Dr. Manish Nagpal sir, who has who has uh, volunteered to be part of this webinar. And we welcome you, sir. We know sir needs no introduction, but sir, we follow his work, we follow his videos and imagings, and we are very much inspired and we follow all those things. Welcome you, sir. And next up, we have Dr. Divakant Mishra, sir, who's the current president of YOSI and a very young dynamic retina surgeon in Lucknow. And last, we have Dr. Kaushik Tripathi. He is a very dynamic researcher as well as retina surgeon in ASG Hospital, Kolkata. But I welcome all the three panelists and my co-moderator, Dr. Karthikeya Singh. For the intravitreal armamentarium, we have two great speakers who will be speaking on Aflibercept in different case scenarios. First up, we have Dr. Mohit Dogra sir, who also needs no introduction. He is at PGI Chandigarh, and again another famous speaker, Dr. Apurva Grover sir. He is at Vision Eye Center, New Delhi. I welcome all the speakers and panelists, and without wasting further time, I would request Dr. Apurva to please share her screen and present her video. Are you there, ma'am?
Yes.
Yeah.
There seems to be a glitch in my video. Can you, not in my video, there is some problem. Is there a lag in my net connection?
No, we can hear you clearly.
Okay.
That is not an issue. Do you want
To try and share once, so we can.
Yeah. We'll just give me a second. I don't know why it's just rotating.
I think you can log out and log in. We'll have the next speaker maybe, right?
Okay, sure.
Yeah.
I would request Dr. Kushal if he's ready, if he can share his video and present.
Yeah, should be fine.
All right, thank you.
So is the screen visible?
Yes.
Yeah. So good evening, everyone. And I again thank UC and UC Retina Focus Group for this opportunity. So I'll be sharing my
Dr.
video.
Kushal, it is not visible yet, I think.
Yeah, I'll just start it. Yeah, I have not started.
All right.
A 51-year-old healthy phakic male presented with left eye sudden onset dimness of vision since one day, following trauma with metallic particle while working. BCVA in left eye was counting finger near face. Anterior segment examination showed inferior self-sealed corneal tear and rosette cataract. Fundus evaluation showed hazy details due to cataract and inferior vitreous hemorrhage. Slit lamp biomicroscopy showed intraocular foreign body impacted at macula. On swept source OCT, IOFB showed high surface reflectivity, suggestive of its metallic origin, along with localized neurosensory macular detachment. Presence of rosette cataract with IOFB warranted cataract extraction, either combined with pars plana vitrectomy or cataract surgery followed by PPV. However, due to exclusive vitreoretina setup, combined procedure was not possible. and delayed IOFB removal in staged manner could worsen the prognosis. The patient was finally taken up for digitally assisted lens-sparing vitrectomy for IOFB removal. The concern of compromised visibility due to rosette cataract was overcome by operating through clear lens area available in between rosette petals. (23-gauge core vitrectomy was performed, followed by triamcinolone-assisted PVD induction. Peripheral vitreous was trimmed. Fluid air exchange was done, and BBG dye was injected under air, and left for 45 seconds for better ILM staining. ILM peeling was initiated from superior side. This was extended circumferentially around IOFB, with the intention of creating multiple ILM flaps. Following extension of sclerotomy, intraocular magnet was used to lift foreign body from the impact site. Using intraocular max grip forceps and 3-pronged forceps, foreign body was extracted via handshake technique. Final fluid air exchange was initiated, nasal to the disc, and flute needle was then slowly moved over the disc. This was followed by flap repositioning within thin fluid meniscus under air. The case was closed with 14% C3F8 gas tamponade. Following IOFB removal and complete absorption of C3F8 gas bubble, the patient underwent cataract surgery. 2 weeks following IOL implantation, BCVA of left eye improved to 3/60. Fundus showed pigmentation at macula. Post-op OCT showed macular scarring with RPE hyperplasia. Thank you for watching.
Thank you.
Great video, Dr. Kushal. I would now invite comments from the panelists. Dr. Manish sir, would you like to please comment on the video?
Yeah, very interesting combination of the cataract and the foreign body. Of course, the prognosis here is poor because of the location of foreign body, the where it's landed up. So we don't expect too much from the central vision, but the surgery was carried out quite well. My only question would be that when we do a surgery like this, we want very good visibility to tackle the foreign body, and you also did a peeling. So normally also when I do a peeling, I want crystal clear stereopsis to make sure that I can see very well. So the fact that you resorted to keeping the lens and doing it is something that at least I wouldn't do. I would do a lensectomy and spare the capsules. The lens could always be put later. We can always, it's very easy to save the capsular sulcus. Even you can keep the bag also. You can just go intracapsular into the lens and aspirate, because these are young patients, and you can keep both the capsules and just make a small opening for So I would prefer a good visibility. I mean, your surgery went very well. I think you could still manage to do a good job with it. But uh, given the cataract and the rosette which you showed at the beginning, that crispness of the view would obviously not be there throughout the procedure. So that would be the only thing. But you did a great job in spite of the visibility, got the foreign body out. And I mean, I think the end result was great.
Thank you, sir. Thank you for your comments, sir. So only thing which I could say that what could have saved me was because I was on 3D visualization system. I believe it does give some advantage for the high definition visibility as well as some depth combination. So probably this could have helped me. That's what I felt.
I don't think the 3D visibility has anything to do with visualization through a cataract. That can only happen if you have an endoscope that is gone in and that's what you're seeing on the screen, then it's different. But here, everything is going through the same plane. So the 3D would not make a difference because even through the microscope, you are seeing 3D. This is just that it's extending it to a screen. So I don't think going through a cataract would enhance it. You saw it out of your experience and you could manage it, but it would be difficult for somebody who's not good at visualization through a clear area.
Especially when we have to
Yeah.
peel also.
Yeah, especially where peeling is also. See, just removing the foreign body, I can understand because you use a magnet and I mean, you just do a very core area and then go in with the magnet, it comes out. Then, okay, you leave it for a second procedure, the cataract, but you also wanted to peel. So, given all that, I would definitely prefer a clear view, over it. I mean, your experience led you through, but sometimes it can be difficult because the visibility is not good. Yeah.
Agreed, sir. Totally with you.
Yeah.
Yes.
So Devang, Dr. Kaushik, would you like to come?
Yes, great video, and I think I totally agree with what Dr. Manish sir has said. Just I wanted to ponder over this that you did the peeling first, right? Before extracting the foreign body. So, what I mean, thinking about the other way around, doing it later. So, what do you think you had the advantages doing it earlier?
Probably what I felt is that we are not sure while removing the foreign body how much the area surrounding will be ragged or what could it lead to. Sometimes it may lead to kind of an maybe some extension of the retinal tissue damage. So that was also one of the reasons why I did multiple flaps. If we see that when I removed the foreign body, few flaps also got dislodged. So my purpose was to do an inverted flap, the multiple layers. But that was one of the advantages that if I had not done the multiple inverted flaps possibly, then probably I could have completely lost it. So that is one reason that whenever I see such patients, I would try to peel from the multiple sides and I will not go up to the edges. I will keep it a bit slightly away from the edge so that what happens is that it does not get dislodged while removal of the foreign body. That is what I felt.
I was just wondering if we would have done it later. I mean, after removing the foreign body. So would that have helped in, conserving the ILM?
I felt that a lot of times the neurosensory detachment takes some sort of progression does happen a lot of times while removing the foreign body. A fluid can gush off within. A lot of times when we see even in the macular table, sometimes the macular hole can convert into localized surrounding detachments. So probably that was my thought process at that time. That led to initial peel and then remove the foreign body.
Okay. Great.
Cause,
Great.
like it can cause bleed because whenever you are manipulating, there can be subretinal or hemorrhage, which can like hamper the view for ILM peeling. Already the view is compromised because of the cataract.
True.
Excellent surgery, Dr. Kusal. Another thing is that what I have seen is when you are taking out the foreign body, the wound should be enlarged properly. If you have not enlarged the wound, then it will fall back. So it happen. It is a common scenario, and because PFCL was not used, it is everything went smoothly as Manish sir said due to your experience and very nicely managed.
Thank you. Thank you.
One point I would like to add, Amit here. So, Kushal, you did a really wonderful job of getting that foreign body from the macular area. but I would like to always combine cataract surgery along with it. So my take is I always leave the patient aphakic, get the foreign body out, and then I place an intraocular lens. So sometimes taking the foreign body out from the scleral pocket becomes difficult, and you can just make a posterior capsular opening, and you can take it from out from the anterior chamber. So that is my way to go about it if the foreign body is large enough.
Yes. Def-
Perfect.
Thank you, everyone, for excellent comments. I think we shall move to the next speaker. Next, we have Dr. Apurva. She'll be presenting on challenging cases in coloboma science. Over to you, ma'am.
Thank you so much, YOSI Focus Group Retina, for this opportunity. Please let me know if you can see my screen. Can you see my video?
Yeah, all
Yes.
good.
Yes.
Okay.
If you can make it
Let me
full
just
screen.
full screen. Yes.
Does it have any sound, Apurva?
Yes.
Okay, we can't hear. Yeah.
Can you hear me?
Yes, we can hear you.
Yes, we can.
Okay. Can we? Don't know why this is happening. Give me 1 second, please. Please let me know if you can hear the audio now. Small eyes, big challenges.
Yes, yes, we can hear now. Yeah.
About challenges posed by the versatile retinochoroidal coloboma. I present two challenging cases. The first case is of a 35-year-old man who came with sudden diminished vision in the left eye for 8 days with bilateral loss of vision since childhood. The right eye was physical. The left eye showed aphakia in the pupillary axis with only perception of light and advanced cataract dislocated in the vitreous cavity with an axial length of only 17 mm. A PPV with frag was planned. This was the challenge of a very small cornea. We know that this is a non-contact wide-angle viewing system where in normal eyes it is easy to have instrumentation with good space. However, in microcornea, the instruments tend to get more perpendicular and because of the O effect keep touching the viewing system lens. With this 4 to 5 mm cornea at our disposal for surgery, we first use the cutter for removing the fluffy outer cortex. An MVR was used to make a sclerotomy for introducing the fragmatome. The nucleus was super hard. While proceeding with the frag, chasing the nucleus more posterior, the fragmatome was getting increasingly perpendicular. This was obviously causing a movement of the viewing system. So, we had to increase the distance between the cornea and the lens. The steady splattering of fluid on the lens due to low scleral rigidity added to our visualization woes. But we frag on undeterred. The smaller fragments drop into the bottomless colobomatous pit, making it harder to access. As you can now see, this is a vicious cycle of trying to access the more fallen posterior fragments of the nucleus. Our instruments get more and more vertical, we move further above the cornea, and our view gets more restricted. We finally manage to finish the frag and close. This is a retina attached at 1 month. Learning points. In microcorneas, port placement will be on the slope of the globe. We can expect increased distance between the viewing lens and the cornea and hence restricted view. There is frequent contact between the instruments and the viewing lens, and these extra long eyes also pose difficulty in access to the posterior pole. Case 2. A 13-year-old boy came with diminished vision in the right eye for 10 days. A type 3 coloboma with subtotal retinal detachment and macula off was seen. The left eye had 636 vision with a fovea sparing type 2 coloboma. His right eye underwent a rough journey of 2 surgeries, in the course of which he developed a full thickness macular hole as well. Considering he was stable for 3 months under oil, he was posted for SOR. The outcome of SOR landed on me like a bomb. Soon he developed a closed funnel redetachment. We then posted him for a revitrectomy and membrane peeling with re-injection of oil. 25 gauge vitrectomy was used. A limbal lensectomy was performed using the cutter. There were thick adherent membranes over a stiff underlying atrophic retina. Those were peeled carefully using forceps. The edges of the macular hole too were thickened and stiff. PFCL was injected. Here we noticed that the anterior PVR was causing the cutter to go subretinal. We also noticed a large break. PFCL air exchange was done to note the extent of anterior traction. Retinectomy was initiated. We can see an extensive retinectomy being performed of 5 to 6 clock hours to relieve the anterior PVR. We see the crumpled edge of retinectomy under air. Subretinal PFCL was removed, fluid restarted, and PFCL re-injected. We had to further extend the retinectomy to completely relieve the anterior PVR. Then, laser was begun under PFCL. We chose to do laser even around the macular hole. After a long grueling surgery, PFCL air exchange was done and retina settled. We now did laser around the other breaks. Inferior PI was done and silicone oil was re-injected. This was the picture on post-op day 1, albeit with a large persistent macular hole. At 3 months, the central retina remained attached. In RD with retinochoroidal colobomas, there are higher risks of missed breaks in primary and resurgeries with higher risk of redetachments. Younger age, missed breaks, nystagmus, low-grade emulsification may all contribute to redetachments. Thank you for watching.
Very challenging cases, I would say now. I would now open the discussion to the panelists. Dr. Manish, sir, your comments, please.
Excellent, Apurva. Very complex cases. We all find them very challenging because the eyes are small, as you showed us quite well how difficult it is in entering the instruments. I use contact systems, but even with contact, to an extent, the same issue happens because those lenses also are wide and your instruments do tend to, as soon as you go posteriorly, those instruments tend to come in your way. So you constantly have to keep shuffling the lens in various directions to get the right view at right place. The only thing is that some of these eyes, the first one you showed was very small eye. Some colobomatous eyes can be extremely myopic. Some colobomatous eyes can have a very small axial lens. So they come in all shapes and sizes. But colobomas, of course, have their own peculiar ways of management. You need to know if the RD associated is coming from the colobomatous area as a break, or if there are some colobomas where the breaks are external and you could tackle them differently. But the ones you showed, of course, were complex. And then the second step that you showed when there's a redetachment post-SOR, that's a very complex situation. I noticed that you did retinectomy under air at that stage because if it's a small area, usually even I would do under air because that's when you notice that the retina is contracted and the air starts going in to a place or there's a tenting and you could make. But if one has to do a large retinectomy, it's always a good idea to shift to fluid because it's more controlled. The air tends to tear apart the retina much wider than you would expect at times and would also make the retina go posterior as it's tearing. So air sometimes can have that effect. So it's always better to shift to a fluid once you are planning a large retinectomy, if it's a large contraction is what I would feel. But I guess these are very difficult cases and one has to relax them. You did a good job finally putting it back in place. Yeah.
Thank you, sir. Thank you. Could I ask a question?
Yeah, of course.
Dr. Manish, I have seen you operate, and I know that you are a big fan of you're a veteran surgeon, and you have a preference for contact lens. I've even seen you balancing and stabilizing the contact lens yourself with your little
Yes.
finger.
Yeah,
So,
I do it. Yeah.
yes. So, do you have any tips for such small corneas? One. Second, would your default option be, or a default choice be, a contact lens for these small corneas? Second, where would your ports be? Do you think that they require a different approach? Where would your sclerotomies be in such small corneas? Does it make sense to make them, I don't know, anterior or posterior? What do you have any tips for me?
Yeah, so I mean, I only use contacts, so I don't change my viewing for these systems. But as I said, I also find it a challenge in small eyes sometimes because these lenses are bigger, made for adult eyes, and they tend to be slightly bigger. They go override the cornea and the limbus and go on the sides at times. So the ports have to, and I use the ones with the flanges so that they remain stable under the visco. You put the visco and the flanges help you stabilize, and also I just make sure that the ports are such, and I keep the lens in such a way that the flanges are not coming in way of the ports. But you could go a little posterior because especially in eyes which have these bad PVRs and all. See, you are already entering behind the retina at times, as you were showing. There's tenting and other. So it doesn't matter hugely if you slightly enter the retina in that kind of a situation. But if you are a little more posterior entry on the ports, the viewing may be better because the lens stability is better. But it is a very customized thing for every eye. I wouldn't say that that's something which can be used for every single eye. So one does change it based on. I mean, I see inside. I put the ports and then kind of get an idea with the light pipe what's happening, and then the cutter port you can always choose to make it at the end. Based on what's happening, how you are seeing inside. After, whether you use your non-contact viewing system or contact with both, you could do that to some extent. But all said and done, it's a challenge. They still don't make very good contact lenses for children, specifically. Mohit might have an idea with ROP. I mean, those eyes are similar to a large extent. They do a lot of ROP work, and you have some tips related to that.
It's difficult to follow up on what you said, sir, but I just had two comments to make, which is a bit regarding what the first case was, Purva yours. I think that was a MPPC syndrome. I think that's something that some of our pediatric retina colleagues would be a bit more aware of, and why that's important to know. So MPPC is an acronym given by Dr. Michael Tracy. It basically stands for microcornea, posterior megalolenticonus, and basically a normal sized eyeball with or without persistent fetal vasculature and chororetinal coloboma. So MPPC. Now that's quite a mouthful, but why it's important to know is because it looks like an extremely small, almost micro-ophthalmic eye, but it's not. It's just microcornea. The entry, so it's like a very small entry. The door is small, but the room is big.
Yeah.
And the lens is big. So MPPC, microcornea, posterior megalolenticonus, with or without a posterior persistent fetal vasculature with chororetinal coloboma. And why that's a challenge is because the approach is small, but it's very roomy behind. It's in fact myopic.
Bottomless.
Yes, and the lens is large for what the cornea is, and hence hard. So all of what you had in the first case, and you have a chororetinal coloboma at the back. So getting in entry is the issue. Actually doing surgery, there's a lot of room back there once you actually get down to it. So one thing that you can do in those eyes particularly is that after you get the lens out, you have to do a lensectomy. After you do the lens out, very easy to do transillumination because they have, as you said, very low scleral, their scleral rarity is low. You'll be able to make out where the ciliary body, where the epithelium ends and the that begins, and that is your point where you get the trocars in. You could have also done that in the second patient. After you got the lens out, that was a normal size cornea. Get the hooks, get it big, get the pupil out big in the second patient, and there you could actually have done a deep anterior scleral depression prior to ports placement, and actually seen that where it was. Not that that would have made a difference because you were already going to do a retinectomy, but it could have been more planned. But in the first one, post lensectomy, transillumination will tell you where the retina is and where the other thing ends.
In fact, the same concept is used nowadays for very high myopic eyes with axial length, very long, where you want to make your port posterior. So people tend to transilluminate and see that where exactly, as he said, the retina is starting. So you can go as posterior as possible so your instruments can reach the macula easier. So the same thing can be used there also. Yeah.
Thank you.
Great comments. Quick comments from Dr. Devakant and Dr. Kaushik.
Yes, I think a lot has been already covered. I just, one point that Oculus has a biome, specifically for these long eyes, and it has those blunted edges. So it makes easier for your instrumentation. So I think that can be one option here. And rest, great cases and very well managed. Yeah.
Excellent cases, Dr. Apurva. Just my question was the role of laser around the macular hole in such cases. Like, how does it help, or like, what is the rationale for that?
It has been described. It's a very unconventional step and a last ditch effort, basically, because this was a patient of redetachments, and macular hole had developed after the first surgery, and the hole was causing the re-RD in the second surgery. Now, this was the third or fourth surgery, including the SOR, it's the fourth surgery. So I didn't want to leave any stone unturned. I wanted the central retina, something to be attached for him. So I chose to kind of barrage around the macular hole as well. It is unconventional, but it has been described as a last ditch for very, very large macular holes.
I think in the situation that you showed it, I would do the same. I mean, that's probably the best way to see, because you're not expecting a huge central vision by whatever means you might choose. Some people may want to put some tissue there, or I mean, it may not have a huge impact. And the best thing, if you manage to put the retina back, is to make sure let's just treat it like a normal hole and do a light laser all around, and at least it'll give you an anatomic settlement for the rest of the retina.
Yes, yes.
So, but otherwise also, would you recommend doing that apart from this case? In
No,
any
no,
other
not
scenario, would you?
no. I mean, something like this. It's not. I don't think in any other situation we don't want to do any laser on the macular area normally or anything. Yeah.
Hi,
I think great.
Apurva. I was wondering when the follow-up was for such a severe PVR to develop, was there like a delayed follow-up?
No,
Uh,
actually, no.
okay.
Post SOR, it happened. It happened within the third week. So my first follow-up post SOR is 1 week, where it was good and I was very heartened. But just at the third week follow-up, this happened. The boy is
Okay.
very smart. He's 13 years old. He knows if one field of vision is gone, he knows complete loss of vision, he knows.
Yeah.
So he's half retina surgeon by now, and he
Hmm.
was like very disappointed with what happened at 3 weeks.
Yeah.
Young age, extreme PVR, I guess.
Yeah. Okay. Thanks.
I think we'll move to the last speaker for today. For the video presentation, Dr. Sarang, I would request you to please share your screen and present your video. Thank you.
Thank you so much, panelists, for your wonderful comments. Thank you.
Is my screen visible?
Yes, it is.
Thank you, Yosi, and thank you for the Retina Focus Group for this opportunity. So I'll just play my video.
Not able to hear anything.
Is the audio not visible? Audio not audible?
Not audible.
I'll just share it again. Sorry for the inconvenience. I'll just play the video again.
Performing vitrectomy
Was the sound there?
Yes.
in an
Thank you.
eye with an optic nerve head anomaly, such as the retinochoroidal coloboma or a morning glory syndrome, is extremely challenging. We present the case of a 32-year-old who came with a retinal detachment in an eye with a massive peripapillary coloboma, simulating the appearance of a morning glory syndrome. It was managed with the help of 240 encircling band with 25 gauge power spinner vitrectomy. Core vitrectomy was initiated and the vitreous stained with triamcinolone. The break was localized inferiorly at the temporal horns of the coloboma. We can see that the posterior hyaloid is tightly adherent to the break edges. The vitreous was incrementally debulked and the posterior hyaloid then systematically removed clock hour by clock hour. This was extremely challenging due to the lack of a central point of countertraction such as the optic disc and the presence of the underlying retinal detachment. The posterior hyaloid was peeled with the help of the cutter and then with the help of ILM peeling forceps. The use of PFCL was avoided due to the large axial length, which may have made removal of the PFCL difficult. PFCL was also avoided as it may migrate subretinally or extraocularly in such eyes. Removal of the posterior hyaloid was aided by multiple injections of triamcinolone, which made the process easier. A fluid air exchange was then done, but we realized that we had been hasty in our decision and the posterior hyaloid was still attached to the anterior margin of the break. We shifted back to fluid and rectified our mistake by further peeling the hyaloid away. Removal of the last remnant of the posterior hyaloid was difficult and led to enlargement of the break. Additional vitreous base shaving was also done. Triamcinolone was again used during this part of the surgery to help in better visualization. Ultimately, the anterior break margin had to be cut to release the hyaloid up to the level of the indentation provided by the encircling band. A fluid air exchange was repeated, and this time no remnant vitreous was found adhered to the break margins. The break and the nasal margin of the coloboma was then lasered. 14% C3F8 gas was injected and the conjunctiva was sutured. The patient is doing well with an attached retina 1 month after the surgery and is under close follow-up. Meticulous removal of the posterior hyaloid with good visualization with triamcinolone is the key takeaway from this case.
Great video, Dr. Saran. I would invite comments from the panelists.
Excellent work. The problem with these eyes, as again, is getting the hyaloid off. These are young patients, and with the colobomatous area, sometimes the edges, the hyaloid is very persistent, attached, adherent, and you showed quite well how you have to make multiple attempts at times, multiple times inject to try and get it off, and at times you have to leave some behind in the periphery and trim it because at times if it's so adherent it can tear off if you make too much efforts. So you showed the whole process quite well, because only that's the key to a long-term success with these eyes, because otherwise it may settle on table, but very easily these eyes be detached once a lot of hyaloid is there. But I'm surprised that you got away with gas. I mean, I would always use oil in a situation, and especially with an inferior large retinectomy that you had to do apart from a colobomatous eye. You know, the only time in colobomatous eye that I would use gas is if I know that the break is a separate, a superior break in the non-colobomatous area, which is responsible for the RD, and that you can judge very well, because when you do the air fluid exchange, if the retina settles posteriorly, then obviously the break is coming from the colobomatous area, and if you see a separate break, then you are sure that that area is separate. Detachment is happening from a break other than colobomatous, and that's when I might choose to use gas. But these eyes, so I mean, happy that you got away with gas in this situation. I don't know how many of you would have used gas in that scenario.
So your comments on encerclage in these colobomatous eyes.
Yeah, that's, I think, see, all young patients, and especially where we are expecting hyaloid to be a problem, it does help, a bit of a tamponade overall as well as inferior is handy for sure. it may not have the same impact on every single eye, but where is the hyaloid which is a problem. Those are the eyes where the encerclage would be good.
Sir, if I could ask a doubt regarding the use of gas versus oil. These eyes, similar to eyes of high myopia or staphylomas, have abnormal contours. Do you feel that gas with its higher buoyancy, therefore with good positioning, may actually be better than oil? It has better contact with the retinal surface then?
I mean, see, theoretically, it could have, I mean, what you're saying could have an impact, but practically, at least I've seen that they, do well with oil. Only problem is, of course, even after removal, the recurrence rates are higher than in other normal eyes. Colomatous eye will have slightly higher rates because we are not always able to laser the full edge. At times the macula is a part of the edge, and we have to spare those part of from the laser, and at times they do redetach even after oil removal. So if you can get away with gas, that's very good. But usually with coloboma itself also, I would prefer oil, and you also had an inferior retinectomy. So I guess the encerclage probably helped you. I mean, that's where probably changed the game. If it wasn't there, I'm sure it would have redetached inferiorly.
Understood, sir. Thank you.
Yeah.
Thank you, sir. Also, today we have Dr. Guru Prasad sir with us. It's a great privilege for us that he has joined. Sir, I would request if you would like to comment on the presentation and the videos that have been presented today. So, are you there? I think sir has joined in and is not around. All right. I think I would request Dr. Devakant to comment and Dr. Kaushik as well.
Yes, I think Dr. Sarang, great cases, and I echo Dr. Manish's thoughts, and I would have preferred oil in this case as well because of the reasons mentioned. Do you again, just stressing on that fact about putting a belt there, do you do it in all your cases when you're handling colobomatous RDs?
Yes, they're generally young patients, they're phakic, we're not aware. Sometimes we're not even sure where the break might be. So I feel it's an extra step which doesn't harm and may always benefit the patient.
Okay, fair enough. Yeah.
Very, very nicely done, Dr. Sarang. Actually, another question was that, like, how did you manage the coloboma? Like, as Manish sir said, like most of us will try to barrage it because there are sometimes this is the visible break, but sometimes the breaks are in the margin only. So, and you are very lucky that detachment did not happen, but my experience is that in such cases, it is always better to go for, and specifically inferior breast, silicone oil is the better choice. I actually have never put gas in colobomatous eye till now. So it was very good luck that it did not detach. And what is the follow-up of this patient?
So the patient had a follow-up of 3 months now. The retina is attached, vision is hand movements. I think because the macula is completely involved within the coloboma. So I did not barrage temporally. I barraged the break and I barraged the temporal edge up to maybe a disc diameter away from the disc margin. And temporally, with no visualization, I could not laser it.
And I also agree that putting a belt is a good idea because you cannot proceed the PVD beyond a certain point because the vitreous is so sticky and it is practically very difficult to move the PVD vitreous separation beyond a certain limit. Very nicely done. Thank you.
Thank you, sir.
Dipanshu, we can have the poll now. In the
Should
meantime,
we have it now or after the first talk, maybe?
okay,
So,
it makes more sense. Yeah.
yeah. All right. So I think we have had great video presentations. Now we would be moving to the intravitreal armamentarium talks. First up, we have Dr. Mohit Dogra, sir. I would request sir to please share his screen and present his talk. Meanwhile, I would request the audience also to stay back. After Dr. Mohit's talk, we will be having the audience poll for all the three presenters. Thank you. Over to you, sir.
Thank you. Thank you, Dipanshu, and thank you to YOSI RSW, the team, for this opportunity. I'm going to be sharing two cases actually of Aflibercept in wet AMD DME case-based insights. So I'm a firm believer of long-term follow-up. When Mr. Gupta from there actually asked me to take out a few cases, I picked out these two, and we'll soon see why. It's not something which is absolutely out of the ordinary, but they'll compare. I'm so sorry. They will run us through a wide gamut of things over 5 to 8 years of follow-up in one case of DME and one case of AMD. So here goes. Sorry. Yes. So the wet. Just a second. I have some issues with visibility on my screen. Yes. Yeah, that's better. So the 57-year-old male presented with I can't see. It's apparently something. So that entire thing is blocking what I've written on top. Yes, with metamorphopsia of the left eye. Sorry, for the past 5 days, and had both eye decrease in vision for the past 2 months. So at presentation, this is 618 right eye. You can see a fibrovascular PED and subretinal fluid and SHREM in the right eye. Also 624 vision in the left eye. Again, a fibrovascular PED, and that is a prechoroidal cleft, which you can see in the left eye but not in the right eye. So this patient was diagnosed as a patient of PCV and was given the options of ranibizumab and aflibercept. At that point in time, this patient, citing financial constraints, actually went and chose ranibizumab. So was given ranibizumab. This is status post second ranibizumab in the right eye. The patient actually had a RPE RIP. You can see that. You can see the change configuration of that fibrovascular PED. You can see the RIP right there. And this is status post in the left eye. The prechoroidal cleft has collapsed, and the subretinal fluid is gone, and the patient had no intra or subretinal fluid. However, the right eye, as you can see, that's what the right eye had. The right eye had a RIP, was scheduled for a third injection because the RIP at that point in time after second injection was thought to be extrafoveal. However, before the third injection could be given after 2 monthly injections in November 17, this patient came to us in July 17, got 2 injections, November 17, came with post a RIP, a massive submacular bleed, which was both sub-RPE and subretinal. The left eye, status post 2 ranibizumab injections with the collapsed, prechoroidal cleft, had no subretinal fluid, interretinal fluid. This patient at this point in time went elsewhere, underwent surgery for this eye, the right eye submacular bleed, with a very poor outcome, and came to us actually with hand motions vision, with the entire thing scarred. Was again and wanted now treatment for the fellow eye. Was again counseled for switching to aflibercept, and this time he consented. Again, most one-eyed patients tend to value, that a bit more. This was 2017, I think, when the ILIA for You Sport program wasn't quite there yet, but they were kind enough to, launch that in TGI on a pilot basis. So we were able to offer that to our patients. And that's how the story of this patient went. A monoocular patient, essentially now. March 18, 618, after 2 aflibercept injections, you can see the response. After 4 injections in July 2018, is starting to get that onion peel appearance, like a multi-layered PED, and get some intraretinal fluid. This is in Feb 19, December 19, after 11 aflibercept injections. This is over 2.5 years. At 618, then the COVID pandemic hit us, and he could come because he was one-eyed, and we were giving injections to one-eyed kind of individuals at that point in time. This is Feb 20, just to compare the octas and how even those mature vessels can respond sometimes, but not that those formed central vessels tend to remain even after the injection. December 21, this is status post 15 aflibercept, 618, maintains vision, responds very well. This is the final follow-up, and this is actually March this year, has received the number of injections that you can see over all of this period, and you can see that now almost requires an injection every 4.5 months, responds every time, has a stable configuration of the PED, which is like a multi-layered PED, gets some intraretinal fluid, and just shows the durability of this product over this period of time. With this, I'm going to come to my second case, which is DME. So a similar 60-year-old male with complaints of decrease in vision and difficulty in reading in the right eye for 20 days. was a known diabetic on insulin and oral hypoglycemic agents. No, coronary arteries, kidney, or cerebrovascular disease. Was treatment naive. He had developed left eye chronic endophthalmitis post cataract surgery done elsewhere a year prior. Underwent vitreous surgery. Underwent re-PPV IOL explant. And when he came, that's what he had. This is the left eye which had undergone 2 surgeries for an end off elsewhere, and essentially had 3/60 vision. So very poor vision in this eye and almost monocular. That's the right eye. So the presentation is July 2014. Had typical cystoid diabetic macular edema. Was given 3 intravitreal ranibizumab injections. IOP was fine. He responded very minimally. At that point in time, we gave Ozurdex, did focal laser. We were still doing focal laser, about 11 years prior to now. He did well, responded. The acuity got better. He was almost, 6.9 and 9. IOP at that point in time was still okay. 2015 Feb, it starts to come back. Second injection was given March 15. The IOP went on to increase after that, although the response was very good. This is, and he needed to be put on 3 topical anti-glaucoma drugs. Was diagnosed as a steroid responder, was essentially monoocular. And because he was on 3 drugs, despite this responding very well, we actually went back to injection Lucentis and wanted to try and see if it worked. It did this at this point in time. So he didn't respond earlier, responded to 3 Ozurdex, but got a steroid response. She shifted him back to Lucentis, and he responded in Jan 16. However, after the first 2 injections, he didn't respond as well. This is the second injection. The response was minimal. After 2 further injections in June 16, he didn't respond. In fact, 2 monthly Lucentis given, the edema actually increased. At this point in time, steroid responder on 3 drugs, essentially monoocular. Lucentis not working. We actually offered him Eylea, and this was prior to the patient support program. And this is the first patient I remember that we put on DME. He was 624. The response was very spectacular given the non-response to ranibizumab. And this is his course. So 2016 Eylea was given. That actually lasted him 4 months, and then only towards the end of Jan did he need another injection in 17. The injection actually kept him dry for about 5 more months. Again, 5th intravitreal injection got him all the way up to 17. However, at that point in time, he complained of floaters, acuity 612, intraocular pressure, still on 3 drugs. After this injection, he had vitreous cells, AC cells, but no hypopyon. That was his media haze. He had post-Eylea inflammation. And at that point in time, in one of the batches, there was an advisory by ASRS that one particular batch of Eylea was actually throwing up what was said to be sterile inflammation at that point in time and not endophthalmitis. So we withheld injections for 6 months, treated him with topical oral steroids for 3 weeks. He was okay. However, when reluctantly, many months later, we re-injected Ozurdex and he continued to respond. This is Feb 18. His pressures got better. We were able to get him off 2 drugs. This is, again, the last follow-up now, and he's received 21 Eylea injections over this eye. Over 9 years, which included COVID, in which he didn't come for 2 years. Acuity is maintained at 618 plus on 1 drug, and just shows the robustness and the long-term kind of effect that this drug has. So 9 years, 21 Eylea injections. If you try and do the math, it just comes to a bit over 2 injections a year with a pretty decent safety profile. And despite that one episode of inflammation during one batch in 2017, and we reintroduced, albeit a bit reluctantly at that point in time, but this patient has had no adverse reaction, ever since. So thank you. Those are my 2 cases.
That was great.
you.
It was some good follow-up and a lot of learning through that.
Thank you.
Any comments from Dr. Devakant or Kaushik Tripathi?
Yes, great cases, I mean, and well documented over the years. So this is what I think Aflibercept, the Eylea for You program, helps the patients, with these chronic follow-ups. And do you feel, I mean, the patient had some inflammation. I'm just, something tangential. I had a case where the patient had a PCP kind of a picture, and he was not on Eylea per se, but he developed some inflammation on some other drug. And he was on a very chronic follow-up ARMD patient, PCV. And post that inflammatory episode, his the PCV quietened, and till now it's been 2 years follow-up. So do you feel these inflammatory episodes have some, impact on the disease process?
That's a great question, Diva. I don't think I have a very good answer to that. But in this patient, if I were to draw the analogy to this patient, of course, we gave the injection when this patient got the what turned out to be sterile inflammation for in 17. For 6 months, we didn't treat. Part of that was because A, we were reluctant, B, the patient was reluctant, and at that point in time, we didn't know what adverse drug reactions were. There was no intraocular inflammation, there was hardly any inflammation that was talked about post. So any injection you gave, if there was some inflammation, it was end off. But the ASRS actually got out advisory, so we were a bit, and there was a particular batch, and it's never happened either before or after that with this molecule. But you're right. For those 6 months, he did not, have any DME. It was almost when even the most subclinical amount of inflammation absolutely vanished from that eye that this patient actually threw up that response, which was at about 5 months. And then we talked to him and he said, "Ki agar kuch hota hai, to we will try and see, but we need to give you this." And we gave it at 6 months. So maybe in a particular subset, because you're talking about PCV, you've seen it in PCV. This is DME. So two diseases, small sample size, but could be.
I have another case with Ozurdex, somebody else's case. So similar picture. Maybe we can discuss that some other time. Yeah.
Absolutely.
Interesting. Yeah.
I have a case who worsened actually after with AMD, developed inflammation, but the AMD didn't respond either. It just kept on getting worse. The injections were withheld. However, the AMD just got worse. So I think that might just be a coincidence. Patient's good luck. Yeah.
Yeah, I think that also, and maybe if the injection that we gave, if it at that point in time wasn't efficacious, but just caused inflammation, then I think it might be a bit of a deviant pathway. Whereas, if the injection that we gave, it did what it did, but on top of that caused some inflammation, might be a bit of a different tangent. Just thinking out loud. I mean, those two
Yes.
might be different, because if it didn't work, then your thought process could go to the drug being spurious, and just other things happening versus the drug acting, but there might be just breakdown of a cold chain protocol, or whatever else, right? Yeah.
Right.
Just a quick question, Mohit sir. On this, as you had given 21 injections in this eye, I have read some report and I have seen only one case in my OPD where the patient had IOP spike after 15th injection of Eylea, and it actually kept persisted over some time that the IOP spike was there. So I read something about it that antigen antibody, they go and sit in the trabecular meshwork and they clog it. So have you seen anything like that?
So not per se. I've also read. So if you were to, absolutely right, Karthik. And in fact, if you were to go through the fine print of the drug trials and when they happen, in fact, they will quote the instances of raised IOP that they will quote post anti-VEGF injections repeated are much more than what we see in clinical practice. And one of the mechanisms purported is what you're saying. It's open angle. And it's ocular hypertension primarily because of almost a trabecular meshwork outflow kind of a thing because of that. But I haven't seen that in real life actually. To the tune that's been actually cited in a lot of the raw data of the drug trials.
Oh. Okay.
All right.
Cool.
So, we shall have the poll right now in between the two talks. Mr. Sai, can we have the poll for the audience? So you must be seeing three names that have been popped up on your screen. So you need to vote the best presenter according to you.
I think Dr. Apoor can start his presentation. Yeah. Dipanshu, what do you say?
Just a minute, just 30 seconds maybe. We are nearly finishing the polls.
Perfect.
We have a good turnout on Zoom today.
Yes, indeed. And I hope everybody stays for Dr. Apo's talk because we'll be declaring the result right after his talk. Yeah.
All right, I would request Dr. Apurv to please share his screen.
Yeah, I'm just sharing. Let me know if everything is visible, clear. Yeah, is my screen
Yeah,
clear,
yeah.
visible?
Yeah.
Okay.
Perfect.
Okay, so yeah, I'll be presenting a couple of challenging cases who I have been treating with Aflibercept. Both of these are actually wet AMD. Yeah. So our first case is a 79. Yeah. Hello.
Please continue, Doctor.
Okay. This is a 79-year-old gentleman with wet AMD. He has been on and he was on treatment with us with ranibizumab for nearly 2 years. Well controlled, BCVA 6/9, multiple injections given on PRN treatment with ranibizumab. And this is when he had to go overseas and he was assured us that he would continue his treatment overseas. However, he came to us then with a follow-up 14 months later, and he says he's been on treatment with Aflibercept every 2 months. Every 2 months, they've been giving him Eylea. However, his vision, as you can see, has deteriorated from 6/9 to 6/24. Clearly, the PED has increased in size. There is some increase in fibrosis. The subretinal fluid has increased, and he is unhappy with his vision. No wonder. Uh, I mentioned to him that he will need a more frequent follow-up and possibly more frequent injections as well. So as you can see with the 1 month following Eylea, his subretinal fluid has increased, has reduced, although there is some fibrosis which is there. So vision at this moment has reduced to 6/24. Uh, the vision is stabilized at 6/24 after the first injection. And following 3 injections, you can see that the subretinal fluid has reduced and the vision has improved to 6/12. And he's been given 3 monthly Eylea injections at this stage. Although there is some subretinal fluid still present at the margin of the CNV, so he was told that he would still have to continue with Eylea injections at this moment, and any increase in interval might lead to a deterioration in vision. So after 4 injections, his vision is still 6/12. However, patient has high expectations. He wants vision to improve further, and he also wants a longer duration drug at this stage. He says, I am unable to come for monthly injections. And you can see that there is some subretinal fluid which is still persisting at the edge of the CNV in spite of 4 monthly injections. So at this stage, we decided to switch him to faricimab. However, as you can see here, after one faricimab injection he came for a follow-up at 6 weeks. And his vision has actually deteriorated from 6/12 to 6/18 partial. Patient also complains of a deterioration of vision, and you can see that some subretinal fluid has increased at the margins of the CNV. Besides some increase in fibrosis in the subfoveal area as well. So, of course, he was reluctant to continue with faricimab, and so were we. We switched him back to Eylea again, and at 5 weeks follow-up, his vision is still stable at 6/18 partial. However, after a couple of injections, he came for a follow-up which was slightly delayed at 7 weeks. And at 7 weeks, you can see that there is an increase in subretinal fluid and also some increase in intraretinal fluid. Some intraretinal cysts have appeared. Some fibrosis is also increasing, and some Shrem has come up at the margins of the CNV. Injection was given at 8 weeks at this stage. And again, the next follow-up is slightly delayed at 7 weeks. And you can see that the intraretinal fluid has increased, the Shrem has increased, and there is also subretinal fluid at the margins of the CNV. So he's clearly deteriorating when the Eylea interval is increased. So we have a few options at this stage. One is to continue with Aflibercept injections, and he has been explained the need for more frequent injections. he would need every 4 to 5 weeks injections. The other option is to switch to another anti-VEGF. We tried that previously with faricimab. However, his vision actually deteriorated instead of improving. Or whether we can actually considering increasing the dose of Aflibercept here at this stage. Maybe give him 0.1 ml of Aflibercept, or maybe use Eylea HD in the future when it becomes available in India. So yeah, I'll move to the second case here as well. This is a 52-year-old lady who came to us with a parafoveal gray lesion and some subretinal fluid. Just to rule out, we did an FFA as well to rule out any CSR. And there was some, this is a scan taken at, a photograph taken at 38 seconds, and you can see some stippling just away from the fovea close to where the PED was. And so probably this is most likely a polyp or an occult CNV, and was treated with injections and was well controlled. However, after a missed follow-up 2 years later, you can see that there is some subretinal hemorrhage at the margin of the lesion, and you can see a orangish red nodular lesion, probably suggestive of a PCV. Patient is continued on at nearly 5 years. The patient has been treated with ranibizumab and is well controlled at 6/9. This is the picture at after 5 years of PRN therapy. However, suddenly what happens is she presents at 6 weeks, and you can see that in spite of ranibizumab injection, there is an increase in intraretinal fluid and subretinal fluid, and the vision has also started deteriorated to 6/12 here at this stage from 6/9. And in spite of being given ranibizumab injections, although she has been responding until now, her subretinal fluid increases, and vision has also deteriorated. The follow-up was also slightly delayed at 7 weeks here, and it kept on getting worse. She has been counseled for Eylea. However, in spite of ranibizumab, she continued with ranibizumab for a while, and the vision deteriorated to 6/18 eventually. Admittedly, she was not following up every 4 weeks. She was a little delayed with her follow-ups. As we switched eventually to Eylea, you can see just after one Eylea injection, the subretinal fluid and the intraretinal fluid have drastically reduced. Her vision also improved at this stage. However, then she came for a delayed follow-up again at 10 weeks, and you can see that the subretinal fluid has come back, the intraretinal fluid is still there, and even though she says she does get a response to the injection, she is not coming to us as we advised, every monthly, and she's been coming for delayed follow-up when she gets symptomatic again at 10 weeks. And again, at a 10-week follow-up, her vision is, still at 6/18. Her fluid is persisting. So even though we counseled her to come for a monthly follow-up, the follow-ups are slightly delayed, and she only comes when her vision starts getting worse again. So to summarize, this is an initial responder with ranibizumab, which is who's well controlled with PRN. However, during the course of a therapy, she turns a poor responder to ranibizumab. Although she gets a better response with Aflibercept, the vision is not maintained with injections every 10 weeks or so, and she obviously needs more frequent follow-up and injections. So I would like to discuss how you would manage a case like that. Admittedly, she's been also not following up as we want her to, coming for delayed follow-ups, as often happens in real world setting. And also, I would like to ask whether there's a role of loading dose when you switch injections, whether you would give monthly injections when you switch. So yeah, these are my two cases. I have some more cases. I think because of lack of time, we can just skip that and discuss these two cases here. Yeah, can I stop sharing my screen now?
Yes, please, Dr. Booth, I think.
Yeah. So we can just discuss these two cases. Clearly, they need more frequent injections, but they also want a longer duration gap between therapies. So how you would manage a case like that? And they, even though they should be coming for monthly follow-ups, they're obviously in a real world setting, often they do delay follow-ups for several reasons. Yeah.
I think, Dr. Apur, something interesting that you brought up about loading doses, when switching an injection. I mean, I'd like to take opinion from everybody else. Dr. Mohit, Dr. Apurva, anybody else they would want to comment?
Purva, you can go first.
Can you hear me?
Yes,
Yeah,
yes.
yeah.
Okay. Nice cases, Dr. Mohit and Dr. Apurv. I don't have much to add. I think you've shown long-term follow-up really well. Even I have some very long follow-ups. So, what is your opinion on treat and extend? Do either of you choose treat and extend regimen primarily, or do you go for PRN? Monthly, of course, is very impractical.
Yeah, so even to extend the therapy, the patient should, be fluid free or well controlled. So, but if every time you increase the duration and the patient presents with the deterioration, then you have to shorten the duration between drugs. So, in these cases, practically it turns out that they need injections every 4 to 6 weeks, and every time we increase the interval between doses, so they tend to deteriorate. So patients like these would actually need injections every month or so. I think there's no other way out, or maybe some longer duration drug like brolucizumab, which also carries a risk of other things like vasculitis, inflammation. Yeah, I would like to get everybody else's opinion as well.
Just wanted to make one comment on your first case, Dr. Purva.
Yeah.
I think both cases were great, and I think highlighted real world, real issues, man, that we want tends to look at. But just so whenever we tend to look at the three components of fluid and trying to looking at activity based on fluid, we all talk about intraretinal, subretinal, and then of course we all, at least in presentations by company people or sponsor talks, have looked at sub RPE component. But for the most part, most people, including me, don't tend to give any credence to sub RPE worsening. Very seldom, if ever, people tend to look at कि IRF नहीं बढ़ा, SRF नहीं बढ़ा, हेमरेज नहीं हुआ, विजन उतना ही है, सब RPE अगर कंपोनेंट ऑफ एक्टिविटी बढ़ गया तो हम इंजेक्ट कर रहे हैं. रियल वर्ल्ड में ये होता है. The only because it is not set in stone as to what is sub RPE fluid or whatever. But one exception to this rule, and it's also briefly what I showed in the AMD case of mine in the patient in the fellow eye that I had a rip. That patient at the get-go had a prechoroidal cleft. Your first patient had a prechoroidal cleft from the get-go, and
Yes.
right till the end, that cleft did not collapse. So having a prechoroidal cleft, at least to me, is the only clinically and OCT significant biomarker that signifies sub RPE disease activity independent of IRF, SRF, or hemorrhage. Why? Because of two reasons. A choroidal cleft tells you two things: that it's very high risk for a spontaneous rip, very high risk for a submacular hemorrhage, which can cause massive blood loss, and a massive bleeding. And it also generally tends to cause more IRF than SRF accumulation, which is typically seen in type 3s. But it also tells you one thing, that once those IRFs, those prechoroidal clefts will collapse, and once you're able to get them to collapse with frequent therapy, that the overlying PED will get a multi-layered configuration, which will be in the long run stable. So will require lesser injections to come. So what I'm trying to get at is, that was a bit of a long prelude, that at no point in time was the prechoroidal cleft closed in that patient, in the first patient. So I think a TREX for that patient was never indicated from the get-go. The
Yes.
endpoint for that patient, where one should try and consider extending the treatment, is when the cleft collapses. And I think once we're able to get monthly till the cleft collapses, and the cleft got smaller, but just stayed there.
Yes.
So that should be the endpoint and ground zero from which we should try and extend. And I think from there we'll be able to extend, very similar to the fellow eye of my patient, who had a small cleft to begin with, was treated extensively, but later on, because they form a very stable configuration, a multi-layered PD. But initially, I think they need to be really hit hard, and once they collapse, then they're okay to go. Just one thing that I've changed in my practice of AMD in the last 3 years based on OCT, not too much else.
Yeah. Thanks. That's useful. Yeah. So there's no way out of monthly treatment for him
For
as
that
of
patient,
now.
for
Yeah,
cleft. If the cleft's not collapsing, that means because we are only monitoring SRF, IRF, and hemorrhage, but the sub RPE activity has never been brought to zero.
True. Yes.
Yeah.
And also in the second patient, I think if you have PDT, then that might be a viable option considering it's a PCV. Yeah.
Absolutely, man. But that, our hands and feet are tied and our mouths are gagged as far as PCV is concerned because we can't even cry about it.
The first patient is also one-eyed in this, so he has a geographic atrophy and the other eye is actually worse. So I was a little hesitant to switch to brolucizumab, where may carry a risk of inflammation. Yeah.
Yeah, clefts actually are bad. Clefts natural history clefts are not great news. So high chance of rip, high chance of massive bleed. If it rips through the fovea as it is, we can't do anything. If he has a massive bleed, even if we try and displace it, he's not going to get back what he had earlier. So I think clefts are not great news. But they are not that bad a news if you pick them up before they have bled, because if treated, once they collapse, then the overlying PD becomes very stable, and then so it's almost a very significant biomarker of activity which needs to be treated aggressively to begin with.
Yeah. Thanks. Any other inputs from anyone?
I think everybody's waiting for the results.
Great discussion.
Yeah.
I would like to thank all the presenters here, Dr. Kushal, Dr. Sarang, and Dr. Apurva for excellent surgical cases, and Dr. Mohit and Dr. Apur for really great insight on how to go about the cases in PCV and AMD and DLV. So it was the first time that I could see that almost equal scores from all the judges for all three presenters. But the clear winner after audience poll is Dr. Apurva Yachit. She got wonderful voting and great support for her from her entire team. So the winner for today's episode is Dr. Apurva. But other two presenters, yeah, you really nice, and we had really good time learning all the cases.
And it was really close. So I hope all of you can come and, join YOSICon and be there and present these cases again. Right?
Just as Apurva's daughter, I think, has joined her to congratulate her at this very moment. So
a few words from her.
She's my
She would have
Few
done
words
most of
from
the editing.
As soon as she heard the name, she was in the screen.
Did she poll as well, Apurva?
I think she polled 10 times probably. She had voted for 10 people probably. All right. I think we have had great sessions. Probably the highest number of audience we have had today in all our sessions put together. I would request Dr. Karthikeya to please deliver a vote of thanks.
So I just said everything, and I think I would like to thank Dr. Manish Nagpal sir, Dr. Mohit Dogra, and all the panel, Dr. Divakant, Dr. Kaushik Tripathi, for being here and making the session great. Looking forward to next two sessions before the final grand finale in the YOSICon. Thank you so much.
Thank you so much. Thank you, everybody. Yeah.
Session very well organized.
Thank you.
Thank you.
Keep up the
Thank
good
you.
work, guys. I think exceptional effort by all of you.
Thank you.
Thank you.
That's right. Thank you.
It's only 3 days school.
Yeah.
Bye-bye. Good night.
Guys.
Congratulations, everybody.